Hello again. This is the last of our 4 lectures on psycho-oncology. It is called Building Psychosocial Programs for Cancer Treatment and Care. What is needed and who may benefit? This 4th part summarizes the possible embedding of psychosocial affairs in the hospital context, addressing not only patient and family matters, but even the possible needs of healthcare professionals, rarely talked about in the context of cancer treatment at time. This presentation will start with an overview of the major achievements and obstacles of international psycho-oncology. In this context, we then will address some cross-cultural issues and afterwards talk more detailed about the particular situation of the so-called cancer survivors. We will then touch the issue of building up psychosocial programs within healthcare settings and introduce to you models, helpful tools, and international guidelines. This includes a model for the delivery of psychosocial healthcare services as well as examples of psychosocial needs and means to address them. As psycho-oncology comprises a multidisciplinary approach towards cancer illness, patients and their families, we briefly deal with the other participants of the healthcare system as well, with physicians, nursing staff, and other healthcare workers, addressing issues like the burden working in this field of medicine, addressing their need of special training and educational programs. The human needs of people who are ill have not changed. They have remained identical through the centuries. The barriers of delivery of truly patient-centered care, unfortunately, have also changed little. The most common criticism made at present by older practitioners is that young graduates have been taught a great deal about the mechanism of disease, but very little about the practice of medicine. Or, to put it more bluntly, they are too scientific and do not know how to take care of patients. This quotes F.W. Peabody from 1927. But who is supposed to deliver such care? The psychosocial aspects of cancer are treated by a range of clinical approaches which vary according to the psychoeconomic status of the region or country in which such treatment is given. In Europe, for example, there is a long tradition of socioeconomic health research, mainly based on continuing advances in public health systems, which aim to secure equal access to all health services. In the late 60s, in the larger European countries such as France, Germany, Italy, and the United Kingdom, national society formalized the psychological and psychosocial activities. In developing countries, belief system and limited access to economic resources are the main reasons for clinical and scientific focus on psychosocial treatment of cancers at more advanced stages. In a country with scarce resources and a low gross national product, psychosocial care will concentrate on palliation, on treatment of pain or other immediate side effects of cancer and its complications. The issue of cancer diagnosis and treatment is also affected by literacy and education, by the availability of equipment or diagnostic tools or transportation means. Most psychosocial support systems, clinical research guidelines and training of specialists in psychosocial oncology are found in affluent countries, but it has been demonstrated that health systems see clear benefits in terms of medical costs in various countries and regions of the world when psychosocial services are provided. One example, studies on healthcare behavior of cancer patients in Africa found that most patients come to a clinic when the disease is in a late stage, and most have not heard about the symptoms of cancer and its early detection. Public health workers do not play an important role as a source of information on health issues and on behavior compared to the influence of elders, neighbors, and friends. Cultural and general belief systems affect the interpretation of cancer as an illness, influence the expectations of patients and relatives, and alter the treatment approach. There are disparities in access to healthcare and cancer research throughout the world. Cultural differences between patients and healthcare workers often give rise to potentially serious bedside misunderstandings and disagreements. So here is one definition of culture. Culture is the sum of the integrated pattern of knowledge, beliefs, and behaviors of a given community. Cultural and general belief systems affect the interpretation of cancer as an illness, influence the expectations of patients and relatives, and alter the treatment approach. Culture influences attitudes towards truth-telling, towards end-of-life decision, towards integrative or complementary therapies. Culture influences views of the therapeutic relationship, the trust in physicians, nurses, and institutions, and disparities in access to healthcare and cancer research. Healthcare professionals carry their own values and biases. Culture shapes both patients and oncology professionals. Therefore, healthcare professionals need to be aware of their own background, beliefs, and values. Dealing with cultural variety requires knowledge, skills, and attitude like respect and curiosity. In the US in 2004, the National Cancer Policy Board and the Institute of Medicine established a committee on cancer survivorship to examine issues related to improving care and quality of life. The report From Cancer Patient to Cancer Survivor, Lost in Transition, may serve as an example how the healthcare system can react. This report outlines the key issues facing cancer survivors and makes concrete recommendations as how to address these problems. We will be facing for the next decade an increased number of surviving cancer patients who are beyond the acute phase of treatment. They are living with cancer and its aftermath, mainly as a chronic disease, its physical and psychological symptoms. Especially for those individuals with chronic illness, specific attention will be needed. But why are cancer survivors so special? Some of the patients' populations have care conditions, needs that are more substantial with stronger barriers towards returning to normal life. These patients group include adult survivors of childhood cancer who suffer from an increased number of chronic conditions, as well as substantial risk for second malignancies, or who are, when grown up to adults, faced with a lack of sufficient information on their prospective physical impairment by their own parents. A second group of patients demanding special attentions are bone marrow transplant patients with both children and adults. They are sustaining considerable toxicities from the conditioning regimes, the risk of graft versus host disease. They have to face high rates of physical and psychological complications, including fatigue, pain, sexual dysfunction, cardiac problems, and psychological distress such as anxiety or depression. I would like to mention here an issue often not explicitly addressed before or after the cancer treatment, essentially especially for female patients, but also for males. This is their possible desire to have children and the option of an impaired reproductive functioning after intense cancer treatment. This delicate and very secret issue may, amongst others, again lead to an enormous distress involving an individual person as well as a social surrounding, sometimes leading to divorce, separation, or social rejection in some communities or regions of the world. Finally, older individuals may meet comorbid conditions in addition to symptoms of cancer illness or due to specific toxicities of cancer treatment, especially cardiac, pulmonary, or renal toxicities, contributing to severe problems on the long run in coping with the disease and its treatment itself and the attempt to returning to normal life. In 1997, the National Comprehensive Cancer Network was established in the United States to determine how to integrate psychosocial care into routine cancer care. And from 2003 on, standards for management of distress were published. The latest version dates to January 2011. In a way, this work, Management of Distress, is a cornerstone of the worldwide effort to integrate psychosocial care into clinical work. In 2008 in Australia, clinical practice guidelines have been prepared and a manual entitled Clinical Practice Guidelines for the Psychosocial Care of Adults with Cancer. In 2005, the United States Congress established a working group under the auspice of the Institute of Medicine to study the capacity for addressing the psychosocial needs of cancer patients, review the available training programs, and identify barriers to access to cancer-related mental health services. The main conclusions of the group's report, Cancer Care for the Whole Patient, Meeting Psychosocial Health Needs, was that there is enough evidence for the inclusion of psychosocial healthcare services in cancer care. In 2008, the European Council has adopted a policy that clearly acknowledges the importance of psychosocial aspects in cancer care. All these guidelines and handbooks are available for free in the internet and may be helpful tools and invitations for establishing psychosocial care within a clinical setting. The IOM report, Cancer Care for the Whole Patient, has provided a landmark document that gives psychosocial aspects of cancer care credibility from a major independent national organization that influences public and private policy. First, it was important to determine what are the essential psychosocial needs. Here you can find a definition of psychosocial services as defined by the committee. Psychosocial health services are psychological and social services and interventions that enable patients, their families, and healthcare providers to optimize biomedical healthcare and to manage the psychological or behavioral and social aspects of illness and its consequences as to promote better health. The model is based upon the assumption that psychological care depends on effective communication. It includes, first, to identify psychosocial health needs. This must be followed by development of a treatment plan that links patients and families to appropriate psychosocial services, supports patients and families in managing their illness and treatments, coordinates the medical and psychosocial care, and includes a follow-up on care delivery to monitor the effectiveness of service and make modification if needed, all of which are facilitated by effective patient-provider communication. We will come to the communication issue in the following 3 subsequent lectures. In a second step, clinical practice guidelines and organizations setting standards were established, taking into account that psychosocial care must be integrated into routine cancer treatment. This table outlines 7 distinct areas as an example of psychosocial needs and formal services to address them. For example, obtaining information, help in coping, material resources, help with work and family, and financial advice. There are several reasons for the development of signs and symptoms of distress for patients and their caregivers, as well as for oncology staff. Patients and their families almost always come to the cancer setting without previous experience, with inadequate information, knowledge, and skills how to best manage the cancer illness and its treatment. The disease, treatment, temporary and permanent physical and mental side effects, possibility of disability and death, and potential devastation are superimposed upon overwhelmed healthcare systems that create unintended, iatrogenic distress. The distress that cancer patients and their families experience is communicated to the healthcare staff, who seldom have an opportunity to process the challenges of caring for so many individuals affected by life-threatening illness. In some ways, the stress and isolation experienced by patients and their families is similar to that of healthcare professionals trying to humanize the healthcare system. For the committed professionals who function daily in highly emotionally charged environments, where simple errors can have dire consequences for all involved, staff can become traumatized. Being able to readily access an organized and effective program of psychosocial service for their patients and families may significantly reduce the likelihood of burnout. Physicians, nurses, and other healthcare professionals all benefit, directly and indirectly, when there are systems in place to identify and manage psychosocial problems through the clinical services, staff support, consultation on patient and family management, education about common psychosocial problems. Here we come to a topic that is seldom addressed in the clinical context. Burnout in healthcare professionals. Burnout is a form of mental distress manifested in normal people who did not suffer from prior psychopathology and who experience decreased work performance resulting from negative attitudes and behaviors. In this slide, I would like to focus on the burnout issue among healthcare professionals, seldomly frankly addressed. The main dimensions of this diagnosis are emotional exhaustion, depersonalization, meaning feelings of cynicism and detachment from job, and the sense of ineffectiveness and lack of personal accomplishment. The impact of burnout is, amongst others, that burnout is associated with suboptimal patient care practice and medical errors on the part of the physicians. Furthermore, burnout was associated with a lower satisfaction with career choice and also with poorer health. Demographic variables and burnout in oncology. Younger caregivers report more stresses, exhibit more manifestations of stress and fewer coping strategies, and are more prone to burnout and stress reactions. Those with more years of experience were less likely to report stress-related symptoms and burnout. Those with more responsibility for dependents, either for children or elderly parents, report more stress. Being single was an independent risk factor for burnout, and females may be more at risk of mental health problems and burnout. Personal factors relevant to burnout in oncology. The compulsive triad in physicians of doubt, guilt feelings, and an exaggerated sense of responsibility can have an enormous impact on professional, personal, and family lives. A diminishing awareness of one's own physical and emotional needs leads to a self-destructive pattern of overwork. A psychology of postponement takes root, in which physicians habitually delay in attending to their significant relationships and other sources of renewal until the work is done or the next professional hurdle is taken. Burnout arises from chronic mismatches between people and their working setting in the following areas: workload, control, reward, community, fairness, and values. Cancer workers in Ontario, prevalence of burnouts, job distress, and job satisfaction. In 1999, Eva Grünfeld and her working group conducted a small cross-sectional mailed survey on all personnel working with the Cancer Care Ontario, the provincial cancer control agency for Ontario, coordinating cancer care through 8 regional centres providing tertiary cancer care. 1,015 questionnaires were mailed and 961 subjects were eligible. Returned a complete questionnaire. 63% for physicians, 80% for AHPs, 65% for support staff. The prevalence of emotional exhaustion was significantly higher among the physicians than among the other professional groups. The same was true for feeling of depersonalization. Feelings of low personal accomplishment were significantly higher among physicians and HAPs. About 1/3 of the respondents in each group reported that they have considered leaving for a job outside the cancer care system. Sources of satisfaction for oncology staff include the following: dealing well with patients and relatives, patient care or patient contact, having professional status and esteem, being perceived to do one's job well, having good relationships with colleagues, and personal ideas. Helpful coping strategies known for decades, a sense of competence, control or pleasure in one's work, team philosophy building and support, control over aspects of practice, lifestyle management, and, not to forget, a personal philosophy of illness, death, and one's role in life. Possible interventions to improve the oncology workplace: communication training, team interventions, for example, continuing process of advanced training, case reviews, intervision sessions on a regular basis, supervision, multidisciplinary ward rounds. This table comprises a summary of necessary skills for psychiatrists in psychooncology. In psychooncology, it's essential to be familiar with the medical issues related to specific cancer sites, medication, and hormonal changes that cause confusion, anxiety, and depression. Management of physical symptoms, which may have a psychological component like fatigue, pain, and nausea, are critical aspects of expertise. Psychooncologists must also know in what circumstances to recommend the range of psychosocial interventions: individual, family, group, dynamic, and supportive psychotherapy, ranging from crisis intervention, sex therapy, bereavement counseling, to behavioral intervention like relaxation. In terms of psychopharmacology, the psychooncologist must know the indications for specific medication, their primary action, and potential drug-drug interactions and possible side effects. All psychooncologists must be able to work effectively with a multidisciplinary healthcare team. The teaching role is crucial as a part of a psychooncologist, not only providing patients and their families with adequate information, but also educating healthcare workers of all professional groups in dynamics, communication, and last but not least, in a better understanding of the particular situation. The training of psychooncologists, of psychologists, psychiatrists, and those trained in psychosomatic medicine was initially conducted within the hospital setting, on inpatient units, mainly in the context of a psychiatric or psychosomatic consultation liaison setting. As the care of oncology patients has shifted rapidly to ambulatory care settings due to more treatments being delivered at home and an increased emphasis on cost saving, training psycho-oncologists increasingly now has to focus on a different setting, such as outpatient setting, home treatment. This leads to greater training needs in management of treatment side effects, fatigue, pain, anxiety, and depressive symptoms. Furthermore, there's a new focus of attention paid on survivors' issues and health problems, as well as on patients receiving palliative and end-of-life care. Training must also address the needs of caregivers who support the cancer patient more than ever before, for example, due to home treatment, while carrying the usual burden of family and work obligations. The economic situation with low reimbursement of psychosocial services hamper not only the patient's care, but also the training issues for healthcare workers and teams. Deficits in the delivery of qualitative oncology care are numerous. We have already mentioned some of them, such as disparities in the provision of care, substandard pain and symptom management, poor access to care, high caregiver burden, and communication deficits across the continuum of care. Several approaches have been made during the last decades, comprising an extensive effort on education and training and dissemination, on educational projects in psychosocial oncology on a national and international basis. Listed above, you find a brief summary. The secret of care. One of the essential qualities of the clinician is interest in humanity. For the secret of care of the patient is in caring for the patient. Again, Mr. Peabody, 1927. Cancer care should be directed to the whole patient, addressing medical diagnosis and treatment as well as psychosocial issues. Psycho-oncology should be regarded as an integral part of the healthcare system, dealing with cancer patients and their families. The care and support for the increasing number of cancer survivors will play an important role in future cancer care, as well as an increased variety of treatment and care settings, such as outpatient care. This implies specific demands with respect to future professional training and education of psycho-oncologists. Aspects of different cultural and ethnical backgrounds, social environment, beliefs, values, and attitudes play an important role in the individual's approach towards the utilization of the healthcare system towards cancer disease and its treatment. Healthcare professionals are at a high risk of developing signs and symptoms of psychosocial distress or burnout, with its implications on the deterioration of patient care. Now we have come to the end of the Psycho-Oncology lectures. I thank you very much for your attention, and I would like to invite you to join us on our 3 parts on counseling and communication.